Welcome. I'm Deidre Cruz. I'm the Deputy Director of the Center for Health Equity, and on behalf of myself and Dr. Lisa Cooper, our Director, I want to welcome you all to the December edition of our Health Equity Jam sessions. I want to make sure yes, we are recording. Great. And I know folks are still trickling in, but we are going to get started here shortly because our speaker has a hard stop at the top of the hour. So we want to make sure we get plenty of time in to hear from her. So our speaker today is Dr. Hilary Seligman. And we will do a bit of a more formal, brief introduction of her shortly, but we wanted to do at least spend a little time doing our tradition that we have at our jam sessions, which is to participate in guessing the fun facts about our guest speakers. And so I see Dr. Seligman is thinking, oh, that's why they asked me those questions. And we will make use of the chat for this fun fact. So you'll learn shortly that Dr. Seligman is joining us from San Francisco. So she's in the great state of California, and where she's lived for quite some time. But in the chat, I invite you to guess which state she came from prior to living in California. Let's see what we get. Okay. Okay. Interesting array. People were hoping maybe you came from Maryland here with us, but so actually, as it turns out, the first entry, and Miranda, I think I saw that this is your first jam session, so it's particularly impressive for you to be the first to guess this. So Texas is the answer. Do you want to share with us, Hilary, how you made the decision to move from Texas to California?
I will. Well, I am an internal medicine physician by training, and I originally moved to California for my primary care internal medicine training program and have stayed ever since. Intended to go back to Texas, but never did.
Ah, okay. Well, very good. And as our other fun fact that was shared, let's see. How can we get you all to guess this one? So Dr. Seligman has newly taken up we can call it a hobby or a sort of a practice in her home, and has needed some assistance from her children, her adult children, to assist her with telling her how to sort of manage this new hobby. So in the chat, let's see some guesses about what that might be.
That was good.
Oh, you like my my intro? Oh, video games, social media influencer. These are some good guessing. Dancing. Okay.
Ironically, many of these are true.
Very good. Do you want to share which one was right? Because it's
Sure.
Again our first time jam session.
The answer I put in there was I have house plants now for the first time in my life that my children help me take care of. But it could have been a bunch of these things: social media, skincare, of course, every adult child is into skincare, and definitely cooking. They're better cooks than I am. So.
Well, very good. Well, thank you for playing along and sharing those fun facts. And so So now, just formally, just to provide a formal introduction, Dr. Hilary Seligman is professor of medicine and of epidemiology and biostatistics at UC San Francisco, where she holds a number of different appointments, including in the Division of General Internal Medicine. She's a proud general internist. I'm saying that to make Dr. Cooper smile. Um, and Hilary is a nationally recognized expert on food insecurity and health outcomes across the life course. And she has a particular interest in programs and policies that can both support food security and also serve to help optimize health. She directed the CDC's Nutrition and Obesity Policy Research and Evaluation Network. She's done that for the last 10 years. And her team runs a program called Vouchers for Veggies, which is a large produce prescription program that's a well-established in San Francisco. We welcome you, and we are super excited to hear from you. You are a key part of our sort of theme for these recent months, which has been on health policy and how it sort of intersects and influences our ability to advance health equity. So welcome, Dr. Seligman.
Great. Well, thank you guys so much for asking me to be here today, and I apologize that I have to leave to teach myself at the top of the hour. My work, I consider myself a health disparities researcher. I am mostly a researcher now, and I spent the early part of my career studying food insecurity and its impact on health outcomes, and have really turned more recently to how can we best support people experiencing food insecurity in opportunities to reach optimal health. And so this is really grounded for me. And I will say I'm going to present today less on my own research and more on where the field as a whole is in terms of food as medicine. And I'll define what that means in a minute. So just to make sure we're all on the same page on why we're talking about this, we know that dietary intake and chronic disease are very closely linked. And that the US ranks last on key health measures compared to other high-income nations. We have invested a lot of time and energy and resources on chronic disease burden in the United States, and the CDC released their obesity maps just last week, and we continue to have an enormously high rate of obesity in the United States. And this isn't a surprise. People in the US have really poor diets. Only 1 in 10 meet recommended fruit and vegetable intake. Most people exceed recommended sodium intake, and only 2% of Americans meet whole grain targets. And this has a huge impact on mortality, and particularly early mortality in the US. It's estimated that 45% of deaths due to cardiovascular disease are related to poor diets. Most people in America want to eat a healthier diet, and the number one barrier to doing that is reported as cost. 60% of people who would like to eat a healthier diet say that one reason they can't do so is because of cost. And it isn't all that surprising, given that 1 in 7 households in the United States experiences food insecurity. The USDA historically has described food insecurity at 2 different severity levels. One is what they call low food security, where the quantity of food people eat is generally maintained, but the quality of food has to go down by shifting food to less expensive, less healthy foods. And that's about 8.4% of the US population. And the other 5.1% with very, very constrained household food budgets have to decrease both the quality and the quantity of their food in order to make a very low household budget work. And so this is the state of hunger, food insecurity in America. And I like to think of food insecurity in the context of what we're talking about today as both the physical sensation of hunger and the coping strategies that people have to employ in order to avoid that physical sensation of hunger. Things like shifting dietary intake to lower cost foods, which tend to be nutritionally poor. Now, I want to say in the context of this that this is not an impossible problem, food insecurity in America. As a matter of fact, what you can see in this graph is something relatively unexpected. I think many of you probably remember during the pandemic seeing a lot of media coverage about skyrocketing rates of food insecurity and lines going around the block for miles on end at food banks for people to pick up food. And while those stories were certainly true, the rates of food insecurity actually went down quite precipitously in the United States during the pandemic. Why? Because we rapidly put into place very highly effective programs and policies to address food insecurity, like expansion of SNAP benefits and waivers to allow people to access benefits more easily. And that had a big impact and kept food insecurity rates from skyrocketing. And what you can see in 2021 is the expiration of those pandemic era policies were related to the increase in food insecurity rates in the United States. And so I say this because we have programs and policies that we know work to reduce food insecurity in the United States. What we really are lacking is the political will or the social movement to use those policies. Not surprisingly, given the historical roots of food insecurity and poverty in the United States, there is very inequitable distribution of food insecurity in the United States, with Black non-Hispanic households and Hispanic households experiencing the highest rates in food insecurity in the U.S., with the exception of subpopulations that the USDA has not historically measured, such as Indigenous, Native American, Alaskan populations, whose rate of food insecurity is even higher in most surveys. I do want to quickly mention that the USDA has notified the U.S. that they will no longer collect food insecurity data in the United States. So after measuring it going back to the 1980s in the same way, this may be the last time that we have food insecurity numbers in the United States. There is a new term that's talked about very frequently now called nutrition security. And the USDA, for a very brief amount of time, defined nutrition security as sitting at the intersection of food security, diet quality, and equity. And although the USDA, even prior to the Trump administration, pulled this infographic down and no longer used this definition of nutrition security, I really like this idea that there is something at the intersection of these three constructs that defines very simply where our field needs to go in terms of creating equitable access to healthy food. And although this is a big simplification, at some level, food security really emphasizes having enough calories, although access to a healthy diet has always been a component of food security. And this new term, nutrition security, really focuses on having the right calories. Everything else I'm going to talk about today, for the most part, is food security, not nutrition security, because that's where our data has been collected, and that's the term we've used since the 1980s. But I do want to acknowledge that more and more people are talking about nutrition security. So we've known for a long time that adults in households with food security are more likely to report having a chronic disease if they have food insecurity. And as the food insecurity in the household increases, the likelihood of having a chronic disease increases. And that's true both among adults and among young adults, where you also see that being in a food insecure household increases risk of diseases like obesity and diabetes and high blood pressure. And so for a long time, the question has been, is the experience of food insecurity predisposing people to poor health? Or is poor health in the United States, because it's very expensive for people, increasing people's out-of-pocket healthcare expenditures, decreasing capacity to hold steady employment, decreasing educational opportunities, decreasing all of these predictors of household income, and creating competing demands like choosing between food and healthcare that would then increase your risk of food insecurity. Because you can imagine that if the arrow goes one direction, we might intervene at food insecurity. And if it goes the other direction, we might instead intervene at financial toxicity related to having poor health. And there have been many studies that have been done over the previous couple of years, previous 20 years examining this. This one I really like because it took place in Canada, where access to healthcare is equitable across the entire, everybody has access to healthcare. What they did is they screened everybody in this one province of Canada for food insecurity and then followed them over an 11-year time period to see who developed diabetes. And people living in food insecure households had more than twice the risk of developing diabetes, even after accounting for differences in other factors. And so we really think that the arrow is moving in the direction from food security to poor health, more than in the direction of poor health to food insecurity, although both certainly exist in the United States. So because of this, I had been pushed as a researcher for many years to try to quantify how much this cost us. And I really was reluctant to do that because I think we back ourselves into a corner when we start trying to think about these interventions as how much they're going to save us or how much things cost us in terms of the healthcare system. But I conducted a study where we looked at admissions for low blood sugar across a 10-year period in the state of California. And admissions for low blood sugar occur typically among people with diabetes, when they have more medication or their medication is lowering their blood sugar more than their dietary intake, and their disease is raising their blood sugar. And what you can see in this graph is that we looked at what day of the month people were being admitted for a low blood sugar event. And in the green line, you see that it was relatively stable across the population as a whole. Your chance of being admitted for a low blood sugar event was pretty much the same on the 9th of the month as it was on the 29th of the month. But in the very lowest income population, that's the red line at the top, what you can see is that admissions for low blood sugar events were much higher through the entire month, but particularly in that last week of the month. And that last week is when people are typically running out of money for food. And so if you continue to take your diabetes medication and your dietary intake goes way down, you may see a low blood sugar event resulting in a hospital admission. This would be just the tip of the iceberg, but these are very expensive events, and it did push us to start thinking about what is the cost. And so we finally did that using this nationally representative data, where we estimated that if you look prospectively, if you look forward in time after someone reports food insecurity, their estimated healthcare expenditures over the next year are about $1,863 higher than someone living in a food secure household, even after you adjust for all kinds of differences between food secure and food insecure households. And if we just multiplied that $1,863 by the number of adults experiencing food insecurity in the United States, we got a very high number, $77.5 billion. And that really got people and policymakers in particular interested in talking about, well, maybe we do need some strategies to try to address food insecurity in the context of healthcare. This is probably not surprising to anybody. I'm sure everybody on this call knows that there is a huge misalignment in the United States between the way we allocate our money to healthcare in the light blue bar and social care in the dark blue bar when we compare ourselves to quote unquote our peer nations, where we spend much more of our money on healthcare and less of our money on social care. And so these emerging problems with healthcare, this burden of chronic disease, is not all that surprising. And really, the way we've started to think about that in the United States is around what you guys know as the social determinants of health, the downstream impact of policies that we've put in place that create unequal opportunity for health in different populations. And so with the passage of the Affordable Care Act, and this is all context for food as medicine, I promise I'm getting there on the next slide. With the passage of the Affordable Care Act, the idea was, let's get healthcare involved in the social determinants of health, or the social drivers of health. And health systems in general were very enthusiastic and rah, rah. Yes, we want to get involved in the social determinants of health. And then when it dug right down to what that actually meant, health systems felt like what they were being asked to do was get engaged in laws, policies, and regulations that create community conditions. And that was political, and that created advocacy needs and the need for lobbyists and going places that health systems just didn't feel comfortable going. But what they did feel comfortable doing is moving not that far upstream, but what came to be known as midstream, which was screening for a social need and then addressing that acute social need. For example, are you experiencing food insecurity today? And if so, can we today help you with accessing healthy food? And that shift from understanding health systems' role as addressing social determinants to then addressing social needs really opened this opportunity to engage health systems in addressing food insecurity. And although I hate the term food as medicine, and I fought against it for a long time, that we now have a lot of momentum around integrating specific food and nutrition interventions in or in close collaboration with the healthcare system. And that is what we call a food as medicine intervention. Now, historically, or at the roots of this movement, these were really targeted towards people who had food insecurity or at high risk of food insecurity. But over time, for reasons that we can discuss or that may become clear, increasingly they are being targeted more broadly towards people with certain health conditions, especially diet-related health conditions or people who have high risk of them. So the first two questions that I am always asked about food as medicine interventions is, are they proven to work? Can they be scaled? And do they have an impact on health? And I'm going to just co-opt the rest of my presentation by saying, yes, we know this, we know it clearly, and it's because WIC has been in place for decades and it's very well studied. It is the largest, the original, as my children say, it is the OG food as medicine program. And we know, based on the success of WIC that has been disseminated into every county in the US, it can be scaled and it can have very robust impacts on both short and long-term health outcomes. And why is WIC considered a food as medicine intervention? If we just look at that definition, it is a specific food and nutrition intervention that offers a specific basket of healthy foods that is provided in collaboration with the healthcare system or with the referral of a healthcare provider based on a specific diagnostic risk. So the rest of this presentation is basically saying if we can do it in WIC, we can do it for populations that aren't WIC eligible. And for those of you who aren't really familiar with WIC, WIC is provided to pregnant and postpartum women and children up to the age of 5. So the theory of change for food as medicine interventions more broadly is that we can identify people in the clinical setting who are food insecure using a clinical screening tool. Usually the one that is used in the clinical setting is called the hunger vital sign. People who screen positive could be referred to a food as medicine program where they would then enroll. Better access to healthy food would support improved diet, improved food security, better satisfaction with clinical care, and that would result in improved health and utilization outcomes. That sounds beautiful on a slide. In truth, it is very complicated. It is very hard to move data between our health system and our community organizations and our food vendors. We have a very difficult time tracking food interventions through a health record. Our community organizations are often asked by healthcare to provide food, how, when, where, and at the price that healthcare desires. And I can tell you the price that healthcare desires is free. And there's a lot of fragmentation of the ecosystem outside of healthcare. But there is a lot of interest by health systems in implementing these programs. And from the perspective of the healthcare system, they generally think of these programs in 3 buckets. The first are the on-site programs, And the on-site programs are the ones where the healthcare partner is really leading the effort. They are usually the ones who are responsible for the staffing and the sourcing of the food. And these often look like food pantries that are in the clinic, or mobile food distributions that are brought to the clinic or the hospital setting, or embedding a SNAP enrollment assistant in the clinical setting. Another model is that the health system just refers out to a community program, and the community program is really responsible for doing most of that enrollment, providing the food, the staffing, and those might look like a medically tailored meal or a medically tailored grocery or a community-based food pantry or a produce prescription program. And then finally, just a reminder that I consider WIC a food as medicine intervention itself, and a clinical referral into any of the federal nutrition programs would be considered a food as medicine program. From the perspective of population health, we think of this very differently. From the perspective of population health, we think about how do we get patients into the right program at the right time, because some of these programs are better for prevention and better for the population as a whole, like food policies, front of package labels to support people in understanding which foods are more or less healthy, or subsidies for healthy foods, for example. Whereas some of these are much higher cost, much more labor-intensive interventions that are right for a much smaller percentage of the population. For example, a home-delivered medically tailored meal. All right, so what do we know about the impact of food as medicine programs? My green, yellow, red here is a little bit dramatic, but the point I'm trying to make here is that we have very, very good data now that food as medicine programs integrated within clinical care can do an excellent job at supporting resource use. People like these programs and they use them. They improve food security. They improve health behaviors, including diet quality. But as your outcomes get a little bit more distal into clinical outcomes and cost and utilization, we still need more data. Data is still being accumulated. And so into that gap has come a lot of modeling studies. I offer this one just as an example because it has a really pretty infographic. But this modeling study shows that if you were to prescribe healthy food in Medicare or Medicaid, by covering 30% of the cost of fruits, nuts, vegetables, whole grains, seafood, and plant oils over a very long time frame, it would become cost effective after 5 years. And it would mostly be cost effective because it is preventing cases of diabetes and downstream cardiovascular disease. And this is a modeling study, but what's really interesting about this is that it's more cost effective than many currently covered medical treatments, including GLP-1s at their current cost. So I'll just throw that in. And so this has really been the impetus for state Medicaid programs to apply for waivers from CMS, from the Center for Medicare and Medicaid Services, to allow for reimbursement for food as medicine type interventions. And you can see that back in the early, 2010, 2014, 2016, a lot of these programs, or a lot of these waivers that were approved by CMS, allowed reimbursement for just screening for nutritional risk or food insecurity, and then more and more for providing nutrition education. But as you get into 2021, 2022, 2023, lots of states were asking for waivers to actually allow healthy food to be paid for through Medicaid. Okay, so that's the place where we are. I'm going to now move for the next 15 minutes probably, or 10 minutes, to talk about the data and then what the system looks like that we're building. So first of all, why is our data on healthy food so limited? Because we all know that healthy food is good for you, that healthy food predisposes people to chronic disease. Your mother's taught you that probably, and your father's taught you that. Why do we need to be reproving that? Well, first of all, I just want to call attention to the fact that food security and nutrition programs are generally better at prevention than at treatment. They are expected to have an impact over a very long period of time, and they tend to have big impacts, but they have big impacts because they have a small effect on a large number of people rather than a large effect on a small number of people. This is sort of the challenge of population health. And so if you anticipate a small effect, to show an impact, you have to have a lot of people receiving an intervention for a long time at a high dose and for a long duration of observation. And those studies tend to be very difficult to do because our current food as medicine programs, because they're often grant funded, with the exception, for example, of some of those programs I showed you that were state level in a slide, a few slides ago, most of these programs are grant funded and reach a small number of people with a small amount of food for a short period of time, and they just are not robust enough to show a really large population health impact. So that's where we are. That being said, there's a lot of movement moving forward, and because I read in some of the materials about who this jam session tends to bring in, that you guys are really interested in the systems, I'm going to take a minute here to talk about what does the system look like and where are the system challenges, because it's very interesting in a field like this, and it's been a real privilege for me to feel like I'm sitting watching a system being built. And so we have this opportunity to build it in a way that really works well for patients or a way that really works well for other stakeholders, healthcare providers, the food industry, large corporate organizations. What is the system that we're building going to look like? And that has exposed a lot of tensions. For example, there have been community-based organizations that have been supporting and advocating for this work and for insurance reimbursement and for engagement with health systems for decades. Those local organizations have invested a lot of time and money in this. They're embedded in communities. They tend to be very culturally competent. They have lots of experience in a nonprofit mission. But these national companies are ready to move. They can deliver food at enormous scale, often to rural areas where our community organizations don't reach. They're really efficient, and they can sign a contract with a healthcare organization tomorrow, and they will know how to bill healthcare for those services, and it's really easy. And our local organizations just don't have that capacity necessarily. There's this tension between focusing on people with a high disease burden or focusing on people who don't yet have disease, but for whom we could prevent disease. When we focus on people with high disease burden, we can prove a return on investment in a short time frame sometimes. So for example, if we're able to get healthy, low salt food to somebody being discharged from the hospital with congestive heart failure, we may prevent a single readmission that costs $50,000 that would make that intervention cost effective for a whole population of people. But it's much harder to show that return on investment when we're talking about, let's say, children for whom we may be preventing a case of diabetes that isn't going to occur for another 20 years. And healthcare insurers, or health insurers in particular, want to see that return on investment within the annual timeframe of their budget. And we just can't do that when we're moving upstream. But when we do focus on prevention, many more people are eligible. We may prevent the onset of disease completely. We might have population as well as individual health impacts. Food goes home to a whole family or a whole household, not just one individual. And it is anticipated that the ROI would be greater in the end. Similarly, given limited grant funds, do we spend that giving a lot of food to a small number of people or a small amount of food to a large number of people? And, on that high dose, in that high dose scenarios, fewer people benefit, but we can have a real impact on health outcomes if we can cover 14 or 21 healthy meals per week. And we know that we can allow people to develop healthier habits that may be sustained after the intervention goes away if we can reach people with that really high dose intensive services. But when we offer a lower dose to more people, we can create potentially generational impacts by feeding entire households, and we may actually have a population level impact in the long run. And then Just a couple more. A lot of this work is being done with vouchers or debit cards that offer a much more dignified experience, support local retail, are really valued by participants. But there is a lot of interest in having pre-selected food boxes that are very efficient, might expose people to foods that they wouldn't have necessarily chosen for themselves, and allow opportunities to do local sourcing that may better support the local food system. So lots of tensions here. And then finally, the shift from the roots of the food as medicine movement is focusing on people with food insecurity and focusing on these interventions as an equity strategy is evolving a little bit towards a focus on chronic disease that seems to be more politically feasible, does not require screening for food insecurity, and may allow wider access to benefits. So, anytime you are implementing an equity-focused intervention, you will still be leaving people out. And so you always have to challenge yourself with who's being left out. And in this case, even when we're focusing on people who are experiencing food insecurity, we are leaving out people with reduced access to healthcare, people who are uninsured and underinsured. And remember, with Medicaid cuts upcoming, this is going to be a larger piece of the pie. It also leaves out people who did not expand Medicaid if a lot of this funding is going through Medicaid. We're leaving out communities that had poor access to healthy food to begin with. If these programs are being implemented in ways that they have to have, for example, a grocery store close by that has healthy food options to begin with, or a medically tailored meal provider that offers a good, healthy meal. And of course, if we are purchasing food for these programs in the same way as we've always done, we will be reinforcing existing disparities in the agricultural sector. So really important things for us to be thinking about. So let me just talk for a few more minutes on where we're going, where the opportunities are. We do have a lot of opportunity to create shared metrics across programs across the United States. And one example is the USDA program called the Gus Schumacher Nutrition Incentive Program. These offer opportunity, they fund produce prescription programs across the United States. And by aligning on certain core metrics, we may be able to sort of crowdsource the impact of some of these interventions. There are opportunities within large health systems with a single electronic health record that have been really forward-thinking in doing this work. And I will call out in particular the VA that's been really engaged in this work, but also the Indian Health Service as well. And then health insurers, obviously, with their claims data. It is my hypothesis or my contention that we have already proven that nutritious diets are good for your health, that increased fruit and vegetable intake is good for your health, and that food security is good for your health. And a lot of funders really push these programs to prove that their food as medicine program improves clinical outcomes. Diabetes control, hemoglobin A1C among people with diabetes, lowers preterm birth rates, decreases hospital admissions for congestive heart failure. What I would argue to most of these funders is that we know better dietary intake and food security will result in better health outcomes. What we really need to do is prove that our food as medicine programs can create better dietary intake and better food security, because we know that if they can do that, that we will get better health if they're implemented at scale and if the dose and duration are sufficient. And what that really means is we have to figure out how can we create our food as medicine programs that are so good, they are so desirable, they offer the food when patients want it, not when healthcare wants it. They offer the kind of food patients want, not the kind of food that providers want. That we can do that so well that fruit and vegetable intake or healthy diets will be improved and that food security will be improved. And that really is a challenge of implementation science. And so this is really my plug for learning your implementation science as you're in training. thinking about different models of implementation science, but in this context, I really like to think about the Re-AIM framework. Are we reaching the right people with our food as medicine interventions? Are we doing it in a way that's effective? Do we have organizational support? Are we delivering it properly and in a way that creates a dignified experience for people? And how do we incorporate that program so that it's not being funded just by short-term grants, but is really woven into the fabric of the healthcare we deliver? So we are at a very difficult moment for the food as medicine intervention, for food as medicine interventions broadly. The Medicaid waivers that I showed on that colorful graph about 12 or 15 slides back have been an important funding mechanism, but Medicaid cuts are likely to slow or reverse that momentum. There's been a lot of innovation within Medicare Advantage and within private insurance because they have so much flexibility in the way they deliver care. But there have been a number of rollbacks of that flexibility, including with the value-based insurance design model, and that is stifling some of this innovation. And so there is a lot of concern that food as medicines may or may not continue under other pathways. And it may be that in the near future, it's actually private insurance where most of this momentum and innovation is occurring. And that would have an impact, I think, on health equity. So food as medicine programs can support food security and healthy diets. Evidence from WIC is robust. I did not cover SNAP today, but SNAP also improves health outcomes. Sorry for the typo. I added that because I didn't go over that, and that's maybe my favorite topic of all is SNAP. There's tremendous momentum right now towards implementing and evaluating food as medicine programs across the United States, but they have been somewhat hampered by the difficulty in evaluation. And so if you're interested in doing some of this work, resist the temptation to reprove that nutritious food and food security are good for your health. Right size the evaluation for the size of your program. If you're reaching 27 people, it's not ethical to look for, long-term weight change, for example. Implementation science studies are really critical, and we need the large, rigorously conducted RCTs. There's been 14 RCTs of food as medicine trials. They're all great. We need to continue that work in order to make sure that we're implementing these in the most effective way possible. So with that, I hope I have allowed plenty of time for some conversation, and I will stop sharing and listen to you guys.
Oh, well, that was just outstanding. Thank you so much, Dr. Seligman. And you can see the applause emojis coming through and comments in the chat as well. So thank you very much. I think you've certainly given us a lot to think about and have taught us a lot. I definitely want to open it up to see if people have questions in the chat or want to unmute themselves. I think we're a small enough group that we could do that as well.
So I'll ask something, even though this was an extremely clear and compelling presentation. So thank you so much. Even for those of us who think we know something about this, I think this was very, very enlightening and helpful. So thank you. You mentioned that there might be other opportunities to advance nutrition security in the context of decreased support from, payers and other programs that have been in place so far. So could you talk a little bit about what some of those other opportunities might be?
Yes. So first of all, I will say that reduction of chronic disease risk is a key strategy priority that is stated in the Make America Healthy Again strategy. And so from the perspective of HHS, there is certainly a lot of discussion of policies that can improve dietary intake across the population. Most of this is focused on reduced consumption of ultra-processed foods. And there are a lot of food policies that are being discussed there that include things related to dyes and additives, but also things like removing ultra-processed foods from school meals. I will say that HHS effort, which is which is talked about a lot, but we haven't actually seen a lot of policy action yet, is coming up against massive reductions in access to federal nutrition programs. And these are in conflict with each other, because when you reduce access to SNAP and other federal nutrition programs, we expect that people's household food budgets will go down. One reason why ultra-processed foods are so ubiquitous in the United States, they're hyper-palatable. Everybody loves them. Of course, people are going to eat them because of that. The other is because they're cheap. And as people's household food budgets go down, they actually are under economic pressure to consume more ultra-processed foods. And so these are in conflict with each other. And I think one thing that is going to be interesting to watch play out is whether the MAHA attention to chronic disease prevention operating through HHS and the USDA efforts to decrease the amount of money we spent on federal nutrition programs, what happens in terms of population dietary intake as those sort of fight with each other.
Yeah, thank you for that. I think there was one question in the chat. Maybe I can just ask for them. Corey was wondering if RE-AIM is the most prevalent framework for implementation science on this topic, or if you think there are others that also are a fit.
That's a really interesting question. I like RE-AIM because it really focuses on the nuts and bolts of how this program goes into the community. But I'll say a lot of the qualitative work, and especially the qualitative work that focuses on the real complexity of how we choose what to eat, has used the COM-B model: capability, opportunity, motivation, and behavior. And part of that is really trying to understand the role of finances or high cost. One thing that I like to say that we've learned from that qualitative work and from the systems work is that lowering costs of healthy food will be necessary but not sufficient, because dietary intake is very complicated. It's not just about cost, even in a food insecure household. And so we have to keep in mind that the most effective interventions, even though I really focus on food affordability and cost, the most effective interventions are going to be multi-level interventions that incorporate all the different reasons that people choose to eat what they eat. And I will mention from this perspective, and I see some hands up, but sometimes I think it's important to say this out loud. Part of the reason that I became really interested in this work is that I am a horrible eater. Most people in this work, like, they love their fruits and vegetables. They eat, they're vegan. I don't know. I love a bag of Pringles, a box of Pringles. I will choose a chocolate chip cookie over an apple every day of the week. Most people would. And so really acknowledging that that's the place where we are, and we have to create policies and environmental changes that will help all of us to be better eaters, because I know that I need that.
I just put in the chat, I feel totally seen.
Yeah, I once gave a nutrition talk at 8 o'clock in the morning. Actually, it was 5 o'clock in the morning in California, where I'm from, but it was on the East Coast. So it was at 8 o'clock in the morning on the day after I arrived on the East Coast, holding a Diet Coke in my hand. And I thought to myself, I don't think I can be a very good speaker on nutrition and security if I'm holding a Diet Coke in my hand. So that's really how I come to this this field. Okay, I'm sorry.
We appreciate that. No, you we definitely appreciate that. So Kimberly was next up. Yeah.
Yes, hi. My name is Kim, and I currently work for the state of Washington, and we are one of the lucky ones that has the Medicaid waiver. And I work as a pediatric dietitian, and I just had a bag of Doritos, so you're also not alone. But I work for the Children and Youth with Special Health Care Needs program. And one of my areas or my projects that I've been working on for years is trying to get better coverage from Medicaid for our metabolic formulas and foods. So I've kind of seen this Medicaid waiver as a way to sneak in PKU metabolic foods under the medically tailored meals, but I'm kind of having a hard time convincing them that this fits under that realm. Do you have like any tips or any thoughts around like how this could fit? I don't know. Maybe it's a big question, but I'm just curious if you have anything in mind about that.
You mean about how to get them better reimbursed?
Or just
Through Medicaid?
how to make metabolic foods fit under the category of those medically tailored meals that are covered with the Medicaid waiver. It's a little outside of their thinking, but I'm trying to make them think that it's inside. And I don't know how to quite do that.
Well, Kim, send me an email because I may be able, if I dive into it with you, maybe I would be able to offer you more better guidance than this. But I will say generically that one of the challenges that we've run up against in implementation of these is that the systems, and mostly I'm talking about the data and electronic systems, are designed to prescribe medicine. They're not designed to prescribe food. And so there are a lot of limitations in the ways that they can get coded and prescribed. So for example, they may ask you for documentation of adherence. They want to know what percentage of every meal was eaten. We can't do that. That's sort of crazy. So my advice to you, and then send me an email, is that we've had better luck when we have sat and thought about how can I push this into a model that is really familiar to somebody who has only prescribed medicine before. And when we can use that language and that framing, it's often much more helpful.
That's thanks for asking that. So Claire is next.
Hi, thank you so much for the presentation. This kind of follows up to what you were just speaking about. So I think a lot of people here saw the news that the nutrition guidelines are changing a lot in the med school curriculum. I was wondering if you could speak about that, if that would kind of answer this cultural shift that you just mentioned for clinicians approaching food as medicine, and how like UCSF is approaching the, I guess, federal mandate.
Are you talking about the nutrition guidelines, like dietary guidelines for America, or are you talking about curriculum being implemented in medical schools?
Nutrition curriculum in medical schools.
Okay, got it. Yeah, so there is a lot of effort to increase the training of physicians in medical school around topics of food and nutrition so that they can be better counselors to their patients. And there is some good evidence to suggest that physicians who have been better trained in these areas are able to be better counselors for their patients. And I want to be careful to say that doing good dietary counseling, particularly for a person in a food insecure household, is very, very difficult. And helping people to create cost-neutral, healthy budget substitutions that are consistent with their cultural background and are desirable, that's a skill in and of itself. And so, yes, I think physicians should know how to talk to people about diet better. They should have a better understanding of diet and nutrition. But do not forget about the dietitian that works with your clinic, because they are experts, and our patients deserve expert dietary guidance because it's very complicated. And there's also a lot of misinformation out there, and the dietitians can often help our patients longitudinally to address that misinformation. And yeah, maybe Deirdre, you want to reflect on that as well.
Yeah, just briefly. Yeah, for sure. We've found in our work certainly that it really does require training. That like health coaches who are trained in using techniques like motivational interviewing to sort of guide the participants, and in this case, it could be patients, through how they can start to incorporate healthier foods into their way of eating, even under a budget, right? But it really does require a skill set, as you said, Hilary. It's not something that the typical medical school course director even is going to be equipped to educate students on. So I know we just have a couple of minutes. I did want to, Ali, I want to try to summarize your question here in the chat, which is about your study that I cite often in my presentations and papers, about hypoglycemia rates being increased towards the end of the month. And Ali was asking about if other factors seem to be at play too, as far as like when the rent is due and other times of the year.
Yeah, so that is the monthly cycle is thought to be related to the fact that lots of people are paid at the beginning of the month, and that rent is typically due at the beginning of the month. And if you spend enough time in this field, what you will hear over and over, or talking to people, although they use different languages, rent eats first. People have to pay their rent first, because if you don't pay your rent, there are dire consequences. But also it's because food expenses can often be dribbled out a couple dollars at a time. I only need $5 or $10 in order to be able to eat tomorrow. So I pay my rent, I pay my gas money so I can get to work. And then, I'll figure out tomorrow how to eat tomorrow, and I'll figure out the next day how to eat the next day. That's a typical pattern in the United States. And that's the reason why at the end of the month, after you've paid your rent and your gas and your credit card bills and all of those things, many households experience a gap in the last days of the month when there isn't enough money for food. Incidentally, you can see, and if you look over the population at expenditures in stores, particularly grocery stores, that purchases go down at the end of the month, and then they skyrocket at the beginning of the month, and they skyrocket at the beginning of the month in direct relationship to when SNAP benefits are delivered.
Wow, no, that's fascinating. Well, I know we are at time. Thank you so much, Dr. Seligman, and we want to again thank and recognize the Bloomberg American Health Initiative for co-hosting and co-sponsoring today's GM session with us at the Center for Health Equity. So thank you again, and season's greetings and happy holidays to all as well. We will see you again in January for our next GM session. So thank you.
Take care. Bye-bye.
It's really wonderful. Thank you.